Motivational interviewing is a counseling method that helps people resolve ambivalent feelings to find the internal motivation they need to change their behavior. It is a practical, empathetic, and short-term process that takes into consideration how difficult it is to make life changes. Motivational interviewing is a style of communication that has been found to increase engagement in treatment and improve health outcomes. It has been applied to a wide variety of populations and is often used to address addiction and the management of physical health conditions. In this four-part training series, QSource examines how clinicians can use motivational interviewing within their practice settings, better understand how patients are motivated to make change, and educate staff in using motivational interviewing techniques. Learning MI involves multiple steps, including understanding the spirit of MI, the stages of change, and strategies for engaging, focusing, evoking, and goal setting. Dr. Maggie Holland from Cherokee Health Systems in Knoxville, Tennessee, shares her insight in implementing motivational interviewing into a clinical practice and how to best engage patients for behavioral change discussions. Part 2 of this four-part series provides a summary of engaging and focusing strategies. Specific communication strategies to enhance patient engagement in their treatment plan over time are described. Methods for focusing on a specific treatment goal to improve your patient's success with making a health behavior change are also reviewed.
Motivational interviewing, Part 2, engaging and focusing. There are 4 processes of motivational interviewing: engaging the patient in their treatment plan, focusing on a specific target behavior, evoking the patient's motivation for change, and collaboratively goal setting and planning with the patient. For this portion of the training, I'll talk in greater detail about engaging and focusing strategies. Motivational interviewing has many acronyms, and we call engaging skills OR skills. The O in ORs is for open-ended questions. We want to go into every appointment with curiosity about what's going to motivate the patient and what ideas they have about what could help them adhere to our plan. For example, asking a patient, what ideas do you have about what will help you to remember to take your medications? If it comes from the patient, it's more likely to be successful. The A in ORs is for affirmations. Stay mindful of your patient's positive attributes and then reflect this to them when you notice them in the clinic. For a patient who misses a lot of appointments but has finally kept one, you might say, "You've really shown your determination by coming to the appointment today." Reflective listening is the R in ORs. This is essentially holding up a mirror to what the patient has said. This helps patients to feel validated and understood. And it helps providers to have a better understanding of what will help to motivate a patient. And summarizing is that last engaging skill. Offer summaries throughout the visit and one at the end. It's a way to check in with the patient about what they've stated so far and as a way to guide the next part of the visit. An MI provider is always scanning for and remembering important pieces of information that come from the patient, including what the patient values, what motivates them to change a behavior, what are those barriers that the patient has to changing a behavior. As you hear each one, remember it like you're picking flowers. Give the bouquet back to the patient in the form of a summary. See, you're concerned about your diabetes or your hypertension and want to improve your health. You'd be more confident you could make healthier choices if you had more support at home. And then at that point, you can start problem solving. What would more support at home look like? There are 2 different types of reflections, simple reflections and complex reflections. A simple reflection is restating what the patient has just said. A complex reflection is when the provider reflects what the patient has said with some added interpretation. And there are several different types of complex reflections. You may want to reflect the emotion that you observe from the patient. For example, this patient says, Different doctors keep telling me different things. You may say, you feel confused and frustrated. It's also important to pause and reflect a value from a patient anytime you hear them talk about a value, because we can often connect their value to a health behavior. This patient says, I can't even play with my grandchildren for more than 5 minutes without getting out of breath. Reflect this back. It's important to you to spend quality time with your grandkids. And for this patient, I would ask more open-ended questions about this. I would want to know exactly what does it feel like in detail when they get out of breath, and what ideas do they have about improving that over time. As a provider, you may know very well that increasing daily activity or possibly quitting smoking may improve this value, but we want to hear it from the patient. Providing a metaphor is also a complex reflection that MI providers frequently use. This patient says, I've already tried 3 medications and making changes to my diet, and nothing is helping. I'm tired of trying. You could say, you're at the end of your rope. Giving a metaphor often provides validation for how the patient is truly feeling. An additional type of complex reflection is called a double-sided reflection. Anytime you hear ambivalence in the appointment, this patient says, drinking hasn't really affected me that much, but it's getting expensive. Offer a reflection. On one hand, you feel that drinking hasn't caused you any problems, and on the other hand, it's really expensive. A tip here is to say and in the middle of the ambivalence and never say but. You think of a time when someone has apologized to you for something with a but. I'm sorry I said that to you yesterday, but what does that do? It erases everything that was just said. And this will happen here too if we say but. But we want to hold up both sides of the ambivalence equally. So make sure to say and. And then end with the patient's change talk. Whatever you end with in your reflection will encourage the patient to talk more about that. And that's what we want. We want change talk to come from the patient. And a last type of complex reflection that I will review is an amplified or minimized reflection. So we're either turning up or turning down the volume. This patient says, I'm here because my wife made me come. To amplify this, you could say, that's the only reason why you're here. Or to minimize it, you could say, your blood pressure isn't really a big deal. The goal here is that we use this type of reflection anytime the patient has extreme language, and it helps them to be less extreme. You want to have good rapport when using this type of reflection, or it could elicit some defensiveness. So you want to already have a really good relationship with the patient. Using these OR skills is essential to matching the patient's stage of change and enhancing a patient's motivation for change. But it's not always intuitive for providers. Think about a patient you're working with who is chronically non-adherent, and reflect for a moment on how you feel when you see this patient is in your schedule or while you're talking with this patient. It would be normal for you to feel frustrated, maybe anxious, sometimes even helpless or hopeless. If you notice these types of emotions, it's because you care about your patients. But if we're not careful about how we respond and react to these emotions, our righting reflex will take over. And this is when we lecture the patient or give them a hard time, maybe give up on them, or just ask too many questions. This is when we spend the whole appointment talking. But ask yourself, what stage of change is the patient in, and what stage are you in? So when you notice your righting reflex come up, because it will, it's normal for it to at times, notice it with self-compassion. It's okay that it comes up. It makes sense that it does, but respond differently. Respond with an OR skill. One question I often receive from providers learning motivational interviewing is how they can give important information to a patient who is pre-contemplative without sounding like they're lecturing them. I tell them to ask permission. Imagine a pre-contemplative patient with suspected alcohol use disorder, history of stroke, and uncontrolled hypertension. Asking the patient permission gives the patient autonomy to accept or decline the information and immediately makes the conversation collaborative. I would recommend initially asking what the patient knows. So for this patient, I may ask them, what's your understanding of factors that affect your blood pressure? And then I would ask, would it be okay if I shared with you some information on the connection between alcohol and blood pressure? I've never had a patient say no, even those pre-contemplative patients. And when they say yes, they'll automatically participate more in the conversation. We've reviewed OR skills and different types of reflections. This is a checklist you can use as a reminder of when to use these strategies. So in the first few minutes of every visit, you want to use these engaging strategies to connect with the patient and engage them in the conversation. And more reflections are indicated when the patient is not in action or maintenance stages of change. Offer reflection when you notice your writing reflex kick in. Remember to respond with an engagement skill. Use reflections when reinforcing change talk or the patient's stated reasons for change. And finally, you can use reflections to reinforce healthy behaviors that the patient is already doing. You've been using your engaging skills with the patient for a few visits now, and they're voicing being in action stage. So now what? Here's where you're going to collaboratively focus on a target behavior. Often patients we see who struggle with medical adherence have multiple behaviors that we want them to change. But we'll be more successful if we collaboratively choose one or two behaviors at a time that the patient is ready to tackle. Not only is this more effective for enhancing patient adherence, but it's also helpful for us as providers who only have a few minutes with each patient. There are 3 possible scenarios. You and the patient may already have a clear focus just by the nature of the visit. So this may be a hypertension follow-up or a diabetes follow-up. There may be several options and you need to decide together. Perhaps the patient has COPD, uncontrolled diabetes, uncontrolled hypertension, and starting to report interest in quitting smoking. And then finally, the focus is unclear and you need to explore together. You might focus with the patient by collaboratively choosing a target goal to work on. For example, you could say to the patient, it sounds like you'd like to improve your overall health, and you've mentioned wanting to cut back on smoking and interest in losing weight. Which one should be the priority for today? Or you might narrow your focus to a specific target behavior. So we're becoming more and more specific and letting the patient be the guide. For example, you're hoping to lose weight because you're worried about your diabetes. When talking about weight loss with patients, we'll start with discussing diet, exercise, or both. Where do you think we should start? To conclude, if you'd like to refine your motivational interviewing skills, I encourage you to make a goal for yourself that matches your readiness to learn motivational interviewing and confidence that you can start applying the skills. And then add to your goals over time. Discussed in this portion of the training, including engaging and refocusing skills, are specific strategies that you can translate into goals. A goal might sound like using at least one reflection in every patient visit, or trying to use more reflections than questions. An MI provider strives to have 2 reflections for every question that they ask. You may set a goal for yourself to self-monitor if you're dancing or wrestling with the patient and reflect instead of react. Or you may have a goal to practice focusing with one action-oriented patient a day. Perhaps you already have an action-oriented patient in mind that you want to start focusing with and practicing this skill. Just remember to keep practicing and build on your goals over time.
Successful management of kidney disease involves behavior changes, including following a renal diet, maintaining medications, following fluid intake guidelines, managing blood sugar, and making helpful choices that are best for each individual patient, such as choosing a modality like home dialysis or transplant, accepting recommended vaccines, and being an active member of the healthcare team. Motivational interviewing strategies can enhance patient education and shared decision-making, and therefore play a critical role in the care of ESRD patients. If you would like to learn more about motivational interviewing, please watch Part 3 of the 4-part series to discover more strategies that the dialysis team can use to help patients with successful behavior change.